Happy, Healthy Hormones by Dr. David Rosensweet. It's a book I recently read. I've also had a couple of great Zoom conversations with Dr. Rosensweet in the past few weeks. I've really enjoyed getting to know Dr. R. We've had kind of a lot in common, mostly our passion for helping women and men to optimize their hormones and transform their lives. Dr. R and I don't see menopause hormones exactly the same way, but we've kind of come to the conclusion that we can both live inside sort of a big tent where there's room for more than one point of view about hormones, menopause, and those types of topics. I'm Steve Goldring from SimpleHormones.com. I help patients and healthcare practitioners with easy-to-understand patient education resources. Most of those resources are about hormones and hormone optimization, and this video is no exception. I want to review Happy Healthy Hormones and throw in some of my personal stories and my personal comments and perspectives that I think are relevant to this open dialogue that Dr. Rosensweet and I are having about hormones and menopause especially. So let's get started. Oh, I did have a little editorial note. In the comment section below this video, there's a chapter listing. This video is longer than most of the ones I usually post on YouTube. Each chapter in the book has a corresponding chapter in the video, but I've also added chapters for my personal stories and reflections kind of mixed in with the book chapters. I'd love for you to watch the whole video all in one chunk. I'll be sure and make it worth your while. But if you can't do that, feel free to take a look at the chapter titles and kind of skip to the ones that are most interesting to you. The book opens chapter 1 with Sarah's story. Well, Sarah is a very dear friend of Dr. Rosensweet's. Sarah makes two major points that have Dr. R sitting up and taking notice. First, Sarah says menopause is natural. Why should a woman go against this process and take hormones? And David, what about breast cancer? Well, this conversation really resonates with me and my personal experience as a patient education pharmacist. There's often an element of discomfort, maybe even some confrontation underneath those questions. Women really want to know the answers to those questions because they're important. Dr. R answers these two questions empathetically, but also emphatically. First, he says, as for menopause being natural, that's a little bit of a hard word to define. Is osteoporosis natural? Is needing a walker or diapers natural? No. You continue to need strong bones. Walking is wonderful. Underpants are much more comfortable, and you never stop needing hormones. He says just because your body's having a hard time producing those female hormones doesn't mean it doesn't need them anymore. Dr. Rosensweet addresses breast cancer by saying the short answer is that taking bioidentical hormones, by that he means hormones that are exactly the same as human hormones in every way, bioidentical hormones not only reduce medical risk, but they also change women's lives. They sleep better, which is a huge deal. Their moods improve, their relationships get easier, their cognitive ability returns, and that's just kind of a short list of the symptoms that women experience. The protection these hormones provide are practically everywhere, Dr. Rosensweet says. Bones, muscles, brain, skin, vagina, bladder. Hormones protect from heart attacks. Women on properly managed bioidentical hormone regimens have a reduced occurrence of breast cancer. Did you catch that? Reduced. This is something that I say all the time. The right hormones, given in the right way, actually reduce your risk of breast cancer. That means it's less than women who take no hormones at all. Dr. R lays out his extremely specific opinions about menopause and bioidentical hormones. He says estrogens should be applied externally to the skin, or it's also called transdermally. He says the same thing for testosterone. Progesterone and DHEA are two other bioidentical hormones. He prefers transdermal application, but he says it's okay to give those orally as well. He talks about the bases used by compounding pharmacies in making bioidentical hormones and says that a large percentage of the compounded hormones are the base. He's a strong proponent of organic oils as a base for hormones, bypassing the possible toxicity of these strong chemical solvents. He suggests that the goal should be attaining optimal dosages of each hormone, estrogen, progesterone, testosterone, DHEA, to achieve 4 objectives. Healthy vaginal tissue and breasts, those are mostly related to estrogens. Zero breast and nipple tenderness. That's the single most common estrogen side effect. Muscle strength, energy, and a healthy, satisfying sex life. That's all about testosterone. Optimal urine levels based on what he calls a 24-hour urine hormone test. That's his favorite. Rosensweet strongly recommends working with a physician, a nurse practitioner, or a hormone optimization prescriber who's experienced in his menopause method. He says training, skills, and experience matter. Dr. Rosensweet's team has a system to help you find a qualified menopause method provider near you if that's something that you're interested in. We'll talk about that later on in the video. Chapter 2 of Happy Healthy Hormones goes into detail about menopause. He does a great job explaining hormones' ups and downs throughout both the menstrual cycle in the month and the life cycle over a lifetime. He brings in a lot of graphs and explains them thoroughly in pretty easy to understand ways. He kind of summarizes the symptoms of progesterone insufficiency this way: sleep disturbances, anxiety, mood problems, hot flashes, breast tenderness, water retention, difficulty relaxing, decreased libido, irregular periods, PMS, fibroids, endometriosis. Estrogen deficiency has a different set of symptoms, some of which may overlap. Hot flashes, night sweats, temperature swings, sleep disturbances, low sexual desire, brain fog, racing mind at night, which might also be related to your cortisol levels, weight gain, which he goes into a lot of detail later in a later chapter, vaginal dryness, painful intimacy, headaches, including migraines, back pain, joint pain, bloating, palpitations or rapid heart rate. He also lists the following as estrogen deficiency symptoms, but I think of them more as health risks. That's a quibble. Osteoporosis and osteopenia, that's the loss of bone strength. Atherosclerosis or heart disease and stroke. Alzheimer's disease. Chapter 3 is entitled Risks and Benefits. Dr. Rosensweet explains the Women's Health Initiative study, which was stopped in 2002 because researchers perceived an increase in the risk of breast cancer among women taking hormones for menopause. I have one small issue to point out with this chapter. The exact quote from the book is, "The Women's Health Initiative announced a very small but statistically significant increased risk of breast cancer, heart disease, and more from hormone replacement therapy, or HRT." Well, I've done extensive reading of this study and made a few videos that highlight what the study report actually says. The study, written by the primary investigators of the Women's Health Initiative, states explicitly that the increase in breast cancer, quote, almost reached statistical significance. The word almost stands out to me as indicating the risk of breast cancer did not reach statistical significance. It almost did. In layman's terms, the study is basically admitting the risk of breast cancer might have been slightly higher due to chance. But both Dr. R and I would agree on these conclusions. The first, properly administered bioidentical hormones don't cause or increase the risk of cancer. In fact, they reduce the risk. Second, cancer comes from a complex mixture of nutrition, stress, toxicities, exercise, genetics, all kinds of things. Third, if there was a culprit in terms of breast cancer risk in the WHI, it was probably medroxyprogesterone. That's a super potent synthetic version of progesterone. Patients who didn't use medroxyprogesterone showed lower risks of breast cancer. Chapter 4, called General Principles of Menopause, is pretty short. It emphasizes the individual differences among women in menopause. No two women are exactly alike. Each one needs to be treated and dosed with hormones as an individual. That individuality involves different symptoms as well as different risks for different women. He says the more you know, the better equipped you'll be to assist in the fine-tuning of your overall health and menopause program. You'll be able to make adjustments that best fit who you are, what you want, and what's working and not working for you. It's all about the individual and her ability to help out. This chapter really emphasizes the individual and her involvement in dosing. This chapter addresses the systems of the body and the fact that all of those systems are connected together. You can't just treat one symptom and call it a day. You have to look at the whole body and the intricate ways that all of the body systems work together. Chapter 5 describes the initial evaluation of a menopausal woman. Dr. R lays out several steps in that evaluation process. The first step is self-evaluation. So asking yourself these questions: what are your goals? What symptoms are you trying to relieve? What health risks are the biggest concern for you? How do you feel about using bioidentical hormones to treat your symptoms and maybe reduce your risks? Step 2 is to find a physician or a nurse practitioner. And then step 3 is actually getting evaluated by your health professional with blood tests like thyroid, sex hormone binding globulin, vitamin D, DHEA sulfate, testosterone, fasting insulin and blood glucose, and maybe hemoglobin A1C. All of those tests are important to kind of find a baseline for the patient. One thing that seems to be sort of missing from Dr. Rosensweet's recommended evaluation is testing for estradiol and progesterone, but his experience is that postmenopausal women all have the same estradiol and progesterone levels, 0. So he's decided it's not all that useful to add those tests before starting treatment. This not testing estradiol and progesterone really only applies to clearly postmenopausal women. Women who are in perimenopause or younger may need some sort of testing of those hormones. Dr. Rosensweet really likes the 24-hour urine testing. It requires collecting urine every time you pee for a 24-hour period. This type of test, according to Dr. R, gives a bigger picture of hormone levels rather than just a single snapshot. Chapter 6 is a detailed look at progesterone. It explains the metabolism or the breakdown of progesterone, as well as the origin of progesterone and other hormones through biochemical synthesis pathways in the body and through other systems. Well, Dr. R's explanation of the synthesis of progesterone reminds me of a video that I recently created. Can we get progesterone and other hormones from yams? My video talks about how yams don't actually contain progesterone, but they do have a chemical precursor that's called diosgenin that can be altered synthetically to create progesterone. You can check out that video at the end if you're interested. Rosensweet describes 200 milligram per mil progesterone in his organic oil base. That's his favorite dosage form of progesterone. He allows for other dosage forms of progesterone, including a 1.8% cream available over the counter. Not so sure about that one. A 3 or 10% progesterone in a carbapol gel, a 20% progesterone cream in a lipoderm base, and various strengths of oral micronized progesterone capsules. Dr. John Lee's book, What Your Doctor May Not Tell You About Menopause, published in '96, has profoundly influenced the thinking of hormone providers, including Dr. Rosensweet. Rosensweet also endorses compounding pharmacists for their knowledge, their experience, and their expertise in making bioidentical hormones like progesterone into transdermal creams and capsules. I'd love to ask Dr. Rosensweet to explain more about his preference for transdermal progesterone. I've done some research into the medical literature, and I've had a hard time finding very much evidence to support transdermal progesterone in terms of uterine protection. The most important reason to use progesterone is to protect the lining of the uterus. It's called the endometrium. This is really only an issue when a woman is also making or taking estradiol, which naturally causes a buildup of the lining of the uterus. There are a lot of providers that I've talked to who've sort of inherited patients from other doctors, and they found some patients who had very thick uterine linings because they had been taking transdermal progesterone from another provider. Admittedly, they weren't in organic oils, they weren't from the Menopause Method, but nonetheless, their uterine lining did not get properly protected. I'd also love to talk with Dr. Rosensweet about the metabolism of progesterone. My understanding is that progesterone is metabolized in the liver after it goes through the small intestine. This is called the liver first pass effect. That just means immediately, especially when a progesterone capsule is swallowed, it goes down into your stomach and then to the liver. And the liver breaks progesterone down to create something called allopregnanolone. That's the specific metabolite of progesterone that helps women sleep. I'm not sure there's as much allopregnanolone produced in women who use a transdermal progesterone. I always recommend oral micronized progesterone as the one form of progesterone that does two things. Number one, it protects the uterus from overgrowth. And number two, it improves sleep through allopregnanolone. Dr. R allows oral progesterone, but I think of it as more of a first option. I do hear from women who have adverse reactions like anxiety and depression and nausea and headaches from progesterone. Those women might be good candidates for this transdermal progesterone, maybe in an organic oil. But I also hear from many, many more women who are desperate for a good night's sleep. They struggle with maybe 2 or 3 hours almost every single night for months on end. These women are definitely candidates for oral micronized progesterone. In my experience, oral capsules should be the go-to progesterone for 85 or 95% of women. Maybe 5 to 15% might benefit from these doses of transdermal oils. Chapter 7 of the book does a deep dive into estrogens. Dr. Rosensweet describes the 3 primary human estrogens: estradiol or E2, estriol or E3, and estrone or E1. Estradiol is the dominant estrogen. It's the most potent. It works the best for symptoms like hot flashes. There's actually more estriol or E3 in a woman's bloodstream, but it's pretty weak as an estrogen and not all that effective as a treatment for most things. Dr. Jonathan Wright has noted that women with lower rates of breast cancer had higher 24-hour urine tests for estriol, and that's had an influence on Dr. Rosensweet. Wright's work is the foundation for Dr. R's recommendation that women in menopause receive an oil-based suspension of 80% estriol and 20% estradiol. Well, I've seen this combination dosage for many years as a pharmacist in my practice. I've also heard a lot of skepticism about estriol and whether there's any solid evidence that it's really as breast protective as Dr. Rosensweet and Dr. Jonathan Wright claim it is. Rosensweet pushes back strongly against oral estradiol because he says it has a potential to increase blood clots and inflammation. He's concerned about the metabolites or breakdown products from that liver first-pass effect that I mentioned with progesterone, but the same thing happening with estradiol. Almost 2 years ago, I got an email from a provider I know who's very active in the hormone replacement area. He was commenting on a video I made where I pointed out the possibility of blood clots with oral estradiol. Here's what he said. "Steve, I love your videos. However, in this one I strongly disagree with points number 5 and 7. Oral estradiol does not increase the risk of deep venous thrombosis, and oral estradiol does not increase the risk of plaque dislodgement in women over 60. That is only Premarin. No longitudinal prospective oral study shows increase in DVT, only retrospective lower quality reviews. Substandard evidence. All studies with E2 show a decrease for cardiovascular risk. If you have one contrary, I'd love to see it, as it would be game-changing." Chapter 8 is entitled Hormone Dose Determination. I really like the concept of titration. Titration is starting with a low dose and very gradually increasing the dose until one of 2 things happens. The first is that a patient's symptoms improve, in this case menopause symptoms. The second is that hormone side effects start showing up. Titration this way gets the patient very involved in the decision about exactly what dose she's going to be taking. It's kind of a straightforward, simple process. I can assume that there can be some overshooting. Some women might just keep going up and up and up, and maybe they don't feel better. But this method of dose determination seems like a great idea. It takes the control of the dose out of the hands of the prescriber, or maybe the pen and keyboard of the prescriber, and gives the control to the patient. Dr. Rosensweet's adamant several times in this chapter, though, that the dosage determined by titration should be confirmed by 24-hour urine testing. He wants to make sure that hormone levels really are optimal based on objective data and not just the way the patient feels. Chapter 9 is long. It's 23 pages long, and it covers application sites in great detail, but I'm not going to do that here. Dr. Rosensweet explains where and when each hormone should be applied and why he comes to those conclusions. He explains his method of stopping hormones for a few days each month, as well as the difference in hormone application in perimenopausal versus menopausal women. Chapter 10 is another long chapter with a lot of detail about dosage forms and how to use them. The chapter answers a lot of questions women may have about organic oils bases and how the drops are prepared and applied to the skin. Real specific things that really only apply when a person is actually using the menopause method. Chapter 11 is about androgens, including testosterone and DHEA. Those are hormones that cause a buildup of muscle tissue. Dr. Rosensweet says that women often start menopause with an adequate level of testosterone, and their ovaries sort of gradually lose the ability to make it for the first several years. Once a woman starts showing symptoms indicating a low level of testosterone, he recommends a transdermal organic oil suspension and never oral testosterone. I think it's a good call. Oral testosterone may have some usefulness, but often it leads to what are called supraphysiologic doses. Well, a little personal story here. My wife didn't take oral testosterone, but because of a mistake that I admit was mine, she received a supraphysiologic dose of testosterone for a time several years ago. Mary's played guitar and sang professionally as a worship leader at several of the churches that we've been a part of over the years. High doses of testosterone totally wrecked her once beautiful voice. It was kind of warbling and cracking like the voice of a 12-year-old boy. She had to lower the keys to a lot of the songs she sang because she just couldn't hit those high notes anymore. She was understandably very upset, mostly at me when she found out that it was really my mistake. Well, fortunately, we recognized that the high level of testosterone could be reversed, and we adjusted her dose. Over time, her voice has returned to normal, and it's as strong and beautiful and powerful as ever. Whew, did I learn my lesson? She eventually forgave me. The funny thing is, I heard the same story from a hormone nurse practitioner in Nashville. She was treating a professional singer. This one was a man, and he was struggling with his voice because of high doses of testosterone. Chapter 12, additional details about hormone treatment, is just that. A lot of odds and ends explaining hormones, nothing that I really want to cover here. Chapter 13, treating elderly women with menopause. The bottom line in treating elderly women is that they absolutely can take bioidentical hormones. The key, though, is to start low, to go slow, and to combine doses where possible. Rosensweet has a special formulation that he calls MM-Elder, which stands for Menopause Method Elder. It's basically a combination designed to make it easier to remember for an older person. It's a compromise, but it's calculated. I have some personal experience in trying to explain how to take hormones to an older woman. My mom is in her early 80s, and she's struggling with some cognitive issues. She never took estradiol or progesterone after she went into menopause because she didn't have all that many symptoms. She's having some cognitive decline and osteoporosis, which actually led to a broken hip for her a few months ago. A doctor prescribed estradiol patches and progesterone capsules. Unfortunately, my mom and my dad, neither one of them can remember how or when to take her hormones. I'd visit their home every 6 months or so and see an almost full bottle of progesterone on the kitchen counter that was almost a year old. I'm pretty sure optimizing her hormones would have made a difference for my mom's cognitive decline, but it's not something that I really have much control over. Chapter 14 and 15 are about patient assessment. Both of these chapters go into a lot of detail about testing hormones and following up on yearly evaluations for symptoms and risks. There's quite a bit of emphasis in these chapters on breast health, especially preventive screenings like mammograms and self-exams and thermoscans. Dr. Rosensweet seems more thorough than I expected him to be about the examination of the patient and going out of his way to assure ongoing breast health and freedom from cancer risk. I don't know how other providers approach these areas, but it really does seem important to me. He mentions these as basically a minimum for an annual exam: a breast exam, a pelvic exam, pap smear, and a transvaginal ultrasound that checks the uterine lining or the endometrium. He talks about partnering with a patient's gynecologist or family practice doctor. Over the past couple of weeks, I've really been personally reminded of the importance of breast cancer screening. Some really close friends of ours, the wife has been relying on thermoscans. Something showed up on a thermoscan that was suspicious, and she was told to come back in a couple of months with another thermoscan. Fortunately, our friend got her second thermoscan, and it showed that there wasn't anything to worry about. Now, Dr. Rosensweet does address the different types of scanning, mammograms and thermoscans and self-exams and those types of things. So that was a big relief for my friends. Another woman that I've had contact with let me know that she had something show up on her mammogram that was suspicious. She's quite nervous about it, but she's getting a follow-up in a couple of weeks. My wife Mary has walked through the cancer journey, including mastectomy, chemotherapy, radiation, with two people, one of her closest friends and a very close relative of hers. One of those women survived and one did not. I have a newfound respect for the lengths that Dr. R goes to assure that women are protected from breast cancer and encouraging them to detect any problems early. It's so important for all the women we love. In fact, my wife is at her annual mammogram right now. I did want to make one more very important point. I've mentioned that the right hormones, given in the right way, don't increase the risk of breast cancer, but actually decrease it. I also want to strongly emphasize one more thing, and that is that hormone optimization can't eliminate the risk for breast cancer. About 1 in 8 women are diagnosed with breast cancer, and that means it can affect almost anyone, regardless of whether they take hormones or not. Dr. Rosensweet mentions bone density testing, which he dedicates an entire chapter to. It's all about the factors that contribute to healthy bones: nutrition and food quality, mineral intake, gut health, exercise. Chapter 17, Weight Issues in Menopause, contains a disclaimer. He says, hold on to your seatbelts. This chapter dives very deeply into weight gain and its relationship with hormones. I appreciate everything he has to say, and I agree with almost 100% of it. That's great because I get a lot of questions all around weight gain during menopause. It's one of the biggest concerns for women in menopause, right below breast cancer and right above hot flashes. Dr. Rosensweet has a comprehensive grasp of everything that goes into weight issues before and during menopause, and there's a lot there. He offers kind of a summary at the end of the chapter. The summary is 3.5 pages long, so the chapter is substantial. Chapter 18, In Praise and Honor of the Bladder, squeeze. 2 words can summarize this chapter: Kegels and estradiol. He's a proponent of hormones, of course, and Kegel exercises, which are pelvic floor strengthening exercises to increase bladder strength and reduce bladder problems in menopause. Dr. Rosensweet includes a long list of references in his Appendices. I haven't really gone over those studies completely, but there's a solid body of evidence to back up most of what he says in the book and in the Menopause Method. He wraps up the book with a concise summary. He says menopause is challenging both with symptoms and the concerns women have about the safety of their hormones. It's possible for women to feel better and reduce their long-term health risks at the same time. The individualized approach of the menopause method is the key to getting hormone levels that are just right. I always say not too high, not too low, but just right. But that's based on 3 factors: symptom relief, a lack of side effects like breast tenderness, and 24-hour urine hormone testing. Dr. Rosensweet is in favor of what he calls lowish dosages of hormones, less than what women had experienced before menopause. The menopause method emphasizes an individualized approach where hormone dosage is controlled by the patient. Patient's symptoms and experience are heavily weighted along with that 24-hour urine hormone testing and input from the prescriber. The menopause method recommends specific dosage forms, including estradiol in a transdermal organic oil suspension, progesterone in the same type of suspension or an oral capsule, testosterone in a transdermal organic oil suspension, and DHEA, kind of like progesterone, is optional, either in a transdermal oil or in an oral capsule. My experience with DHEA is it's a little harder to compound in a transdermal dosage form. Rosensweet really leans on the experience and expertise of compounding pharmacists in creating those individualized dosages of hormones that he needs. He goes into great detail about monitoring and regular evaluation and testing of the women being treated with the menopause method, especially in terms of breast health and early breast cancer detection. I really appreciate aspects of the menopause method explained in Happy Healthy Hormones. The level of individualization. Sometimes it's called precision medicine. It just makes a lot of sense. It's about individual women needing really specific doses that are really only practical when they're compounded by a compounding pharmacist. I appreciate the involvement of the patient in determining her dosage something that I hadn't really thought about before, but it means she has a lot of input and maybe some responsibility in the process of achieving her goals. The care and thoughtfulness of Dr. Rosensweet is really admirable. The Menopause Method approach is especially good in terms of evaluation, testing, and preventive medicine. I read a lot of books about health and hormones and wellness. I'm always looking at them with a little bit of a critical eye to make sure they'll work for the layperson. Happy Healthy Hormones is one of the rare exceptions where I think regular people without a science background can follow along with it and find it really interesting. I really appreciate the accessibility of this book for both healthcare providers, who will definitely get something out of it, but also for patients without any scientific or medical background. If you're a patient and you're interested in the Menopause Method, click the link on this video and I'll put you in touch with Dr. Rosensweet and his team. They can give you more details and maybe even help you find a provider who's been trained in the method. If you're a hormone practitioner and you're interested in the Menopause Method and Dr. Rosensweet's training program, I have a link for you to let me know about that, and I may be having some more materials out later with it. Well, thanks so much for watching. Click the like and subscribe buttons and click the little bell to get notified anytime I post a new video here on my YouTube channel. Let's keep in touch.